join us via Skype.
Thank you very much, David. I'm very pleased to be joining you. I apologize for not being able to be there in person. That sometimes travel arrangements and time zones would prohibit that. But I'm pleased to join you.
Thank you. And also joining me today is Ted Waz. And Ted, I will let you introduce yourself if you could do me the help and honor.
Sure. I'm the CEO of the Opinion Economy, Executive Vice Chairman of Red Lambda. The Opinion Economy is a consumer data company using blockchain as a service. Red Lambda is a cybersecurity data in motion company. I'm also a former CFO for Cleveland Clinic in Abu Dhabi. I served as a CIO for the East and West Coast for WellPoint and Executive Director for Research and Development for United Health Group, and serve as a consultant and vice chairman for the Axle 360 Group. And we work with payers and large provider networks on a consultative basis. And I'm also working with OPITA Global, and I specifically work on consulting with presidents and ministers of foreign governments around healthcare, homeland security, and refugee management.
Great, thank you, Ted, very much, and thank you for joining us at the last minute. Now, our next speaker, who is also our keynote speaker at the conclusion of day one of the General Summit, is Pradeep Goel, who is the CEO of the Solve.Care Foundation. You'll get a proper introduction from me at 3:15, but Pradeep, welcome and thank you for joining us. So certainly your role in discussion is very appropriate given your role with Dr. Hanekom and his organization. So on that note, I think I'd like to go ahead and ask a few core questions to all of you about, in essence, the application of blockchain in your respective business, and very specifically with accountable care organizations, and how you think the application of a blockchain platform can be useful to your respective businesses. So Dr. Hanekom, you're there. If you want to go ahead and kick this off and give your perspective, I think that would be helpful.
Yes, certainly, thank you, David. One of the major pain points in healthcare delivery is the segmentation of information and data as required by the various stakeholders to be able to deliver healthcare and administer healthcare benefits. And so, what blockchain can do for us on the provider side, and in large integrated delivery systems such as myself, is really empower the patient to a decentralized technology such as blockchain, where each participant of within the system can have the essential information at their call at the point of service, so that they can make better decisions and just simplify the administrative process of delivering healthcare. So we're very excited about the application of blockchain, firstly to empower patients, and then secondly to remove many of the pain points that exist in the simple administration and transactional capacity within the healthcare system. So we believe that by removing these pain points, we want to get better doctor-patient relationships. We're able to deliver healthcare in a much more efficient manner. And as a consequence of that, we should see not only patient satisfaction go up, as well as provider satisfaction, but also see the direct impact on clinical quality and clinical outcomes. So from an accountable care organization perspective, where we're trying to deal with the 4 pillars of accountable care, those being delivering better care, lower total medical costs, more satisfied patients and providers. This is one of the most incredible technologies that we've seen in the last few years, and we believe it will certainly move the whole process forward towards better outcomes, which is why we exist. So we're very pleased about that.
Okay, thank you. Pradeep, I think that given your role both with ACN and obviously with your development as the founder of Solve.Care, perhaps your perspective would be absolutely worthwhile for the folks to hear about how you think blockchain can be transformative for ACOs.
Thank you, David, and thank you, Dr. Hanekom. Just a brief introduction, we are working with Dr. Hanekom and his organization, which is Arizona Care Network, based in Phoenix, Arizona. And they are implementing our technology today to implement provider-centric use cases, namely around how do we pay the providers accurately, timely, and with transparency around how their value-based payments are being calculated, how many rewards they have earned, and how many rewards they could have earned if they had done certain things during the course of care delivery. So that use case is being rolled out on our platform, so that's the context of David Randall's statement that we're working with ACM. Now, in general, speaking about the ACO market, one of the fundamental tenets of accountable care organizations and their business, their value proposition is care coordination and measurement of care. So where we see a lot of opportunity in working with clients like ACM is to bring the core value of a distributed ledger that keeps all the parties in sync and brings the appropriate level of transparency between these parties that have agreed to work in a value-based contract. Those have agreed to share the rewards and the perils of good outcomes and bad outcomes. So in that scenario, whether you're a care coordinator, a provider, an institution where the patient is visiting, post-discharge therapist, and so on, all these people have a need and a common objective to make me well faster as a patient at the least cost to the system. That's the whole idea of accountable care, right? We're moving from fee-for-service to outcome-based payments, and that's where all the coordinated parties now have an alignment of interest in ensuring that whatever is happening to me as a patient, all the parties who need to know without having to go to some portal or without having to have some kind of a very complex manual process behind it. So the core value here of blockchain and our platform, which is a healthcare coordination, administration, and payment platform, is to align these incentives, to give the physician the information they need, give the patient the abilities they need to make good decisions, and to keep the ACO and the payer behind the ACO fully aware of what's happening, and to do so without having to somehow magically integrate all the centralized systems that we inherited and that we all have, because they will never really integrate in time for these programs to work. So the objective of blockchain is to serve as a connective tissue that gives me transparent, decentralized fabric on which I can align and coordinate the activities of all my stakeholders. That's what we're doing, use case at a time. And there's a long journey ahead. We're only rolling out 3 or 4 use cases today, but working with Dr. Hanekom, we have laid out a roadmap for the next several years, and all the other use cases that provider, patients, and institutional organizations will implement on the same fabric.
Thank you, Pradeep. So, Ted, I think your perspective would be absolutely worthwhile to this discussion, given your extensive experience, and most notably with one of the largest, most respected healthcare organizations, that being the Cleveland Clinic. So your perspective on both use cases and application of the technology in and around provider networks, I think would be useful.
Sure. So there are a couple of facets to this, and I'm going to talk both from my provider experience, but also from my experience leading payer organizations and working with payer organizations across the U.S. So accountable care organizations have a fundamental role of improving health while concurrently being fiduciarily responsible. And what blockchain does is it provides an opportunity to, as Dr. Hanekom said, be able to empower the patient to make more informed and timely decisions about their own health care. And as Pradeep has said, that by setting up the technology in a way that allows them to do so and have access to it in clear, crisp manner, provides an opportunity for smart contracting to take place, which actually allows for faster payment for providers, which today is a major dissatisfier, that it takes so long for providers to get paid for services that they provide. It also allows us to do so in a transparent but secure way. Now, that may seem like contradictory terms, but they're not at all. The blockchain allows for a tamper-evident collection of data, and the transparency is between those who have informed rights of access. So those are the types of things with the hash keys that are used and smart contracting that today blockchain will allow a use case at a time to evolve for providers like Dr. Hanekom over at ACN and others across the United States to be able to implement and really improve the overall quality of healthcare while lowering the costs. And we should also be able to start to normalize some of the easier outpatient activities. And that's not to say that we would start legislating from the payer side, but rather we would acknowledge that there's a series of events that take place and they have a normal course of action. And that should always be monitored and implemented by the physicians.
Okay, Pradeep, you want to add anything more?
I think maybe Dr. Hanekom would like to add to that. This is his area of expertise.
No, I agree very much with what was said previously. As we attack the quadruple aim around quality, cost, patient, and provider satisfaction, one of the areas that's critical to the satisfaction piece of both customers, the physician and the patient, is the administrative simplification of the current process to deliver healthcare. For example, if you just think through the multiple processes that occur for a patient to walk into a physician's office, to be identified, to have the insurance verified to make sure that the benefit covers the visit, the process of then seeing the patient, then generating a medical record to capture that, and then the entire back office process to submit a bill to the payer. That whole process adds an incredible amount of time, resources, and it's expensive, and there's a large component of the total medical cost of delivering a healthcare system. As we know, healthcare administration is anything between 9 and 21% of the bill or the total cycle of the process. So at the Arizona Care Network, as an accountable care organization, we believe that we need to address what I would consider the fifth aim, which is administrative simplification and administrative cost as part of our journey. The process of delivering better care at a lower cost and being financially sustainable is a long-term endeavor that has multiple stakeholders and takes a long time to achieve. By addressing the administrative simplification and reducing the administrative cost through blockchain technology and suggested smart contracting and decentralized ledger, we can address that component as well. I think we need to address all 5 components to be able to get a sustainable, high-quality, value-based health delivery system. So I'm very proud to work with Pradeep and various other stakeholders on this matter. And the administrative burden that exists today as a result of legacy technology systems, policies, laws, and procedures are as much a part of the financial sustainability challenge that we face in the United States as any other lifestyle, culture, or challenging factor within the ecosystem. And so addressing that at the same time as the other activities, I think makes absolute sense for us in terms of getting a sustainable, high-value health delivery system.
And one of the key things from an administrative and payer perspective is, just as Dr. Hanekom talked about, identity management. Is this patient the patient that I recognize? And if we can take that problem out by using blockchain and solutions like the one that Solve.Care has provided, we've eliminated an enormous component of the reason for rejections of claims, delays in payments, dissatisfaction for patients. Because the leading reasons for rejected claims are patient not found, there's not a match between the patient, service not covered, which meant there was some confusion about what the policy of the patient had and the service that was provided. And if we could eliminate those two, we're eliminating nearly 80% of the defect that we see on a payer adjudication of claims. When you add to that the KYC, the Know Your Customer, or KYP, Know Your Patient component of that tied to a smart contracting, all of a sudden, in an ultra-secure way, we are providing a better, faster service for physicians. We don't need to be able to have the 20 minutes in front of every office visit where you come in and you fill out the same forms, you get the same copy of the HIPAA regulation. We could do that all electronically, we could do it smoothly, and it could just be a verification process rather than a restatement in pen and ink. And those are really big differentiators from a payer perspective.
If I can add to that, one of the really interesting use cases we are seeing is the consent management. Consent from patient to provider, patient to payer, patient to employer, broker, provider, and medically informed consent. We sat down with again, Dr. Hanekom and I sat and we designed out and mapped out 16 different types of consents that occur related to a health episode, beginning with ability to share medical records and or to be billed for services and so on. And these consents have a number of issues. Administrative cost is one, time it takes is another. The third is, how do you revoke it? How many of us have ever gone to a physician's office, given consent, and switched physicians and gone back and revoked the consent from the previous physician? I don't know of anyone. Maybe there is, I would like to meet the unicorn who has actually gone back and cleaned up their consents, but they stay in perpetuity. So the notion is that we don't even know how our consent is being delegated, deferred, and used years after we gave it, and how it flows further down the stream. So having that transparency alone reduces a lot of risk and cost, not just for the patient, but also for the provider. We can trace very clearly who gave consent for what duration, at what period of time, when the consent was revoked. So actually implementing patient security as it is meant to be, although we never really achieved that because paper forms are an imperfect tool of doing that. From a provider perspective, it's a huge risk reduction. From a patient perspective, it's actually transparency on who is looking at my data. And when you get into scenarios like, my daughter turns into an adult, at what point does she take control of her medical records, and what point she actually knows that mom and dad can't see this because I haven't given them consent for this medical data now that I'm an adult. These are things that really get handled in a rather haphazard and expensive way, all contributing to cost, confusion, and ultimately barrier to proper care. So there are dozens such use cases, and a similar one, finally, to Ted's point. If you look at, I built adjudicating systems, many of you probably have dealt with them, where we go through the process of figuring out how much to pay the doctor, and the bill that came in or the claim that came in is accurate. And every adjudication system in the world always does the same 5 things. First, I gotta verify, is the physician real, and under what contract do I have with this physician? Under what contract vehicle are they billing me? Individual, institutional, value-based, and so on. So I need to know the physician, KYP. The second, I need to know who is the patient, is it mine? And were they insured with me the day they went to see the doctor, which is 90 days ago? So what plan were they under? That's my second big problem. The third problem I need to know is, which is the simplest one, what did the doctor do? Well, we got codes for that. So that's the easiest problem. The next is, how much do I pay the doctor for this code, which is typically my rate contracts, which I have to apply based on who the KYP is. And the last but not the least is, was this the care medically necessary? The good news is that 90% of the claims, we never ask the question, was the care medically necessary? Because we rely upon our physicians to do that. But the first 4 things take up all the money. So if we could eliminate those 4 questions, who is the patient, who is the provider, when did they go to see the doctor, and were they covered that day, and if those are part of my care ledger, I can pay vast majority of my claims not post-submission, but at the point of care. Which means I can tell the physician, don't send me a claim. I don't need it. Your patient wallet and your consumer provider wallet have already given me the 4 data points, so I'll send you payment or coins or whatever you want to do. So think about the administrative efficiency of a physician getting paid before I leave the physician's office by my insurer. And I know we talk about float, and I'll let Ted talk about float, but I can tell you that the value proposition from a payer-provider perspective far exceeds any money I'm going to save as a float. Those are the kind of value propositions that we see the chain bringing to the seats.
Yeah, there's an illusion that large insurance companies make a huge amount of money off of float, and that's just not the case. The real value is being able to pay quickly and electronically and accurately. Because if I can adjudicate a claim electronically, fully electronically, the simple claims adjudicate at, and I'm just going to make this number up, so you can't quote me on it, but let's say it's like $1, just for ease of math. If I have to do an intervention on that claim, it goes from $1 to to $5, and then from $5 to $25 if I have to have 2 interventions. If I have to stop and look for prior authorization or medical necessity, or do a check to make sure all of the tools that were authorized for the service were then used, then I'm up over $100 to adjudicate a claim. Now, that's directionally right. The numbers are off, but directionally you see where I'm going. Those things can be eliminated by making sure that you have the right cards, the right information, and that it's all done assigned to the blockchain.
So, I think, Ted, that brings to a discussion both from earlier this morning with the gentleman from both Hash Health and Hyperledger about what type of ROI would you want to see in terms of the deployment of a blockchain? What do you think is relative based upon your direct experience?
Sure. Based on my experience within the United States, and it's different around other places, if I could see a 12% ROI, for me, that's a victory. And I know I've talked to some other folks and they've said, well, if I can break even on this and I can just eliminate the problems as I move forward, I've got recurring value. But a 12% is where I get really interested. That's where I start wanting to put millions of dollars at this, because that's where all of a sudden I can start growing exponentially and I can start applying other use cases. And then when I can link those use cases, my 12% is going to grow. It's like rolled throughput yield. If I can eliminate steps in the process and eliminate defects, my sigma rating goes up, I get more revenue going out faster at a lower cost. That's a victory for me as a payer perspective.
I think having been on the payer side as a CIO, my primary objective was to process more at lower cost. Every year we went to the board with a hat in hand saying that my IT budget needs to grow by 7%, 12%, and the question was, how come you're spending more money to do the same thing you did last year? And it's a valid question, and our board would ask that, and we would have to come up with good rational reasons, but the reality is we were never really advancing consumer or provider experience any forward. And when we did that, it actually added to the cost and we struggled to show ROI. So to Ted's point, depending on the organizational priorities, I've always found that our board responded very strongly to when we said this is going to change the patient's experience, it'll improve the outcome, it'll reduce the friction we have with our partners, the providers, and we're going to see an accelerated resolution of complex cases where all the money gets spent. We all know 20% of cases spend 80% of our healthcare dollars. Multi-chronic disease, dual eligibles, and so on and so forth. So I think in this scenario, it's very obvious. The low-hanging fruit is in areas where we have either massive care coordination needs, I have a designated case manager who's dealing with a multi-chronic patient who is susceptible to multiple readmissions in a single year. I know I'm going to spend between $500,000 to $2 million on this family alone. It clearly is a need for acute coordination. You can ROI that all day long. And those are the complex cases. The reason we can't do them well today is because we rely upon a system that is designed for the median, not for the outliers. I don't know of any eligibility enrollment payment system that was designed for the outliers. They're all designed to handle the bell curve. So all my outliers kill me. And what I need is a solution that addresses the outliers that are requiring millions of dollars of investment in a very constantly variable environment. So the idea of a coordination framework on which I can actually implement scenario-specific use cases or cards or whatever the mnemonic you want to use, and I can deprecate that cost even by 10%, the ROI gets very, very big, very quick. So I'm speaking on what Dr. Hanekom does on a daily basis, but giving you a technological perspective on that.
Dr. Hanekom?
I'm sorry, you really actually, you're cutting out significantly, so I'm not hearing the question. Could you repeat that, please?
Yeah, so we just had a discussion about ROI in terms of deployment of the technology, and both Pradeep and Ted gave their perspectives on what type of ROI was relevant in terms of deployment and ongoing investment in terms of any technology application. So I think your perspective, given that you're in deployment
on that. So firstly, I think return of investment on the deployment of blockchain can be measured in multiple ways. we must not underestimate the value of improved patient satisfaction as well as provider satisfaction on the financial viability, sustainability, and profitability of the various stakeholders. So improvement in the patient and provider satisfaction, which are two of the customers of health plans, would result in significant improvements in the uptake of their various products and services. So from a health plan perspective, any time you can make the experience of the financial transactions between the health plan and the member, and between the member and the provider are smoother, and you can take away the pain points, the more likely to buy your products. So I think there's a direct impact on the desirability and the choice of buying a specific health benefit product from a payer perspective. On the provider side, let me describe to you the norm in terms of payment. A patient will arrive in your office and produce a member benefit card that you will scan or document, etc. And on the assumption that that member at that moment is still a member of the health plan, and therefore the health plan has a financial responsibility to pay you should you deliver medically necessary services, the physician then sees the patient, does the documentation, submits the bill, and they may or may not get paid sometime in the future, depending on a very complex system of requirements. I don't know of any other business that will deliver services to customers in that economic model. So I think rapid payment, a positive, real-time identification of the member, the medical necessity, and the appropriateness of the service will lead to significant provider satisfaction with the members of specific health plans. Certainly within my network, since there's a significant demand for the time and services of my providers from hundreds of thousands of patients on a daily basis, if a provider has to make a choice between seeing two patients of equal severity and equal need, then that patient who brings the finances and where the payment system is the smoothest and the most guaranteed is likely to gain access first. And so I think there's a lot of downstream return of investment, positivity or benefit to the payer to make sure that they take the pain points away. And then in terms of the administrative costs of delivering healthcare, if one takes an assumption that a very well-run health plan has about a 9 to 10% administrative cost to administer the benefits, and you can reduce that cost by 1% of the total medical cost, that is about a 10 to 12% savings on administrative cost per year. So I agree with the previous speaker that a 12% reduction in administrative costs for the various stakeholders in healthcare is a significant return of investment, and that's simply on the administrative component. So I agree with their statements. I think there is a significant return of investment, both direct and indirect, and I think it can be measured in multiple ways in a relatively short time.
And I'm glad that both Pradeep and Dr. Hanekom approached the clinical side of deferred health issues. So it's a very important part of the whole return on investment. The administrative savings is terrific when you apply blockchain solutions. But if you can help somebody not go from being a small issue to a complex issue, well, the savings there are enormous. And when you look at that across population, because one of the things we haven't talked about yet is the benefit that Dr. Hanekom's system is going to see over time by using a blockchain solution. And that is that he's going to have a searchable database that he'll be able to reference that will help, for example, payers be able to do better underwriting. And when we do that across multiple systems, the cost of underwriting will actually go down. The cost of risk goes down because we can see clinical pathways that lead to overall improved healthcare. And that's truly what accountable care is about.
Great. Given we've got less than 15 minutes left, I'd certainly like to open it up to the audience for any questions any of you may have. So we'll start right up here. If you could identify for Dr. Hanekom's benefit who you are.
Sure. Webb Burns, Vice President of Business Development for Crillian Clinic in Roanoke, Virginia. I'd like to ask, and thank you, the panel has been really informative. I'd like to get your feedback as to how or what the major EHR vendors, Cerner, Epic, are doing with blockchain, either now or planned in the future.
So I have a view on how blockchain can and cannot serve electronic health record. Having been a consumer or a buyer or user of these systems, I would say that one thing the chain is not is a good database. It is a poor database in many ways. So in terms of replacing a centralized repository of large volumes of clinical data, the chain is not well suited for that as a replacement. What it is really good at is tracking access and auditability of who accessed the data, when, how, why, and serving as a portal through which data can be accessed and exchanged safely, but not as a permanent repository. Now, I can't speak for Cerner and Epic and others as to exactly how they plan to use it, but we do hear initiatives being rolled out by all of them around the chain. Where we have chosen to focus at Solve.Care is to let the EHR do what EHR does, but to extend its capabilities to the edge, to the consumer, to the physician, to the social worker, to the caseworker, who is not going to be intrinsically able to access nor should access the EHR. Nobody's going to suddenly open up their entire EHR to a caseworker who is not employed by the clinical organization, nor is there a reason to. But what the chain does let you do is to identify the events that require effective coordination and then allow those coordination endpoints to occur and for data to be shared with full traceability as to who saw it, why, when, where. So it becomes as a governance layer on top of EHR, but doesn't replace it. So that's my perspective on the data itself. Another layer, which I touched upon earlier, is the ability to manage consent around the data that is stored in EHRs. It really does a lot. I predict in the next 2 to 3 years, we're going to see a shift in how data is seen as residency and ownership. When I go see a doctor and clinical records are generated for my visit, who owns the data? Is it mine or is it the physician's? The answer is yes. We both own it. It's a co-owned, it's a data that we co-own, that we both have rights to it and we both have a reason to protect it. But we also both have a need to share it. You as a physician have to share it with a specialist, or internally for consultation or for medical research. I as a patient need to share it when I switch doctors and when I need to manage continuity of my care. So we co-own it, and that co-ownership is very ambiguous. It's almost like whoever has the data owns it is the model we live in today. And when I need to go get my own data from the resident holder of data, I have to go through hoops to get it. We can completely change, and we will change that model, where co-ownership of data can be effectively managed, controlled, governed, and monitored, and the people who co-own it can either co-share or individually share. So not to get too esoteric about it, we are building use cases around consent and use of data, that is in EHR or EMR or even my hospital information systems, whatever the terminology you want to use, and give patient the appropriate control and access and visibility and auditability of how my data is being used and how do I consent and take away consent from it. So that's our specific way of applying blockchain to the electronic medical industry.
Dr. Hanekom, do you want to comment on Epic or Cerner or EHR and blockchain?
Yeah, I think I agree with Pradeep. I think the EMRs are designed to do what they're designed to do in terms of interoperability and the release of information across the ecosystem. Certainly within the Phoenix area, with a complex organization like myself, we still have significant challenges in getting basic information to the point of service in a timely manner so that we can make good decisions and better decisions. So I see blockchain as the interoperability engine and an extension of the EMRs. I think foundationally there is a set of information that really should be in the hands of the consumer, that consumer being either the patient, the physician, the care coordinator, etc. And that information needs to flow in a secure manner and be part of that end user's control. And I'll give you an example of that. If you think back to many decades ago in Africa, we had a piece of paper called the Road to Health map. It was a card that every mother had with her where their child's birth date was written in, all the immunizations. Wherever they went, they carried this card with them, or this passbook, that people could document information in. So it didn't matter where the mom took the baby, which health system, which facility, etc. There was a portable, available, real record that was held in the custody of the mother and the child, that they could access care that would be recorded in that. That is a very, very simple blockchain, if you think through that, non-electronic from 50 years ago. And it's really about reinventing the wheel. It's not reinventing the wheel, it's taking well-designed concepts and using blockchain to automate it and scale it in a very secure manner. And so, foundationally to better patient care is an understanding of the patient, of their unique healthcare needs, as well as the information that they have to have custody of, that they can choose to share whenever they need services from the service provider of their choice. And I think blockchain is the perfect technology to start doing that process. So I don't see it replacing EMRs. I see them as supplemental, value-added capabilities around interoperability and patient empowerment that I think will help the whole process.
Thank you. Go ahead, please.
Yes, hi, I'm Charlie Hewitt. I'm a semi-retired IT guy. I was involved pretty heavily in the development of the clinical health information exchange in Rhode Island. So my question really is about the cost in terms of the impact on jobs and the response of, say, unions and employers where the employees that have thought they signed up for a lifetime tenure with their insurance company, only to find out that now the big file cabinets don't have to be there anymore, and so they are faced with job disruption and maybe layoff. How do you deal with that?
So I'm actually going to jump in on that, because currently for every blockchain job posted today, there's a need for 14 people. So there's a huge gap right now between those people who are qualified and the need to fill those spaces. So as in any industry, when you introduce new technology and it becomes foundational, there is a transition, which means that some people are going to have to go through retraining activities. The idea that we have one job in our lifetime is no longer a valid assumption. It's anticipated that my son, who's 14, will have 36 jobs by the time he's my age at 55. Now, that's very different than my dad, who was in the Navy for 20 years and then he worked for GE for 20 years. He had 2 jobs. And so that's, I've had 7 or 8 very different but somehow knitted together jobs. And it's been through technology disruption. So we're going to see that continuing to evolve. So for whether it's for trade organizations or unions or affiliates, being part of embracing the evolution of technology and ensuring that that's part of their operating focus is critical, I think, to how blockchain can serve that population as well.
If I may just respond to that, from an operational perspective, putting on my old payer hat, I would add to Ted's comment. Blue Cross is a lifelong employer in many states, and that's where I come from. What we tried to do always was to move them up the value chain. Our proposition was not that we're going to get rid of this incredibly tedious, repetitive, error-prone function, manual claims adjudication, and automate that so you don't have a job. The goal obviously is to say, okay, how can we bring you into more cost or outcome management? So a simple example is our eligibility call center. 75 people around the clock answering questions. If we eliminate the eligibility call center, one, we eliminate about the 8% miss eligibility rate, which means I'm denying on average 80,000 people from care that I should have not denied them because I have that error rate. And I've been training people for decades, and it still exists. It's a persistent threshold below which we cannot drop. So we're going to deny some care when we should never do that, and upon appeal we'll reverse our own decision and tell the kid, yes, absolutely, you're authorized to have this care. We always struggle with that bottom, the intrinsic, the very stubborn error rate in human action. So what we want to say to our eligibility staff, keep doing the error rate, this is the best we can do, or can we say we're getting rid of this function, we're moving you into case management or care management or population health management. So there is no panacea, right? Some people simply would not transition, some would move to IT, and some would move to a more higher value function. But it is a transition, no doubt.
Okay, thank you. Last,
I just
no,
like
go
to
ahead,
follow
please,
up,
please.
Because that's all great, and I just wonder when executive management looks at a proposal to put in a blockchain solution, which will say eliminate a lot of people that are working in building a provider directory, for example. Is that the cost of retraining those folks and making them eligible for new jobs? Is that built into the investment proposal? My experience as a CIO was that it wasn't.
So, as a CEO I was a CEO for a global healthcare organization, and absolutely, we took very good care of our folks. And it is part of looking, because I put a lot of time and money into educating and investing and training those folks. So it costs me a lot more money to have to shift to go get a new person than it does to help the group that I have transition and morph over to a more value add for both them and for the organization. So I can't speak for every organization, but I do know that the folks that I've worked with, it's always been part of the discussion.
Thank you. Time for one last question. Please go ahead.
Yeah, thank you. My name is Tom Gross. I'm an attorney and also on the faculty at George Washington University, and I'm also from Cleveland. Just real quick, since we're almost out of time, on the ownership of health records, my understanding on that is that that's controlled by state law, and HIPAA does not address that issue. HIPAA addresses privacy. The states have their own individual laws. So the only state that I'm aware of that has passed a law that says the patient owns the health records is New Hampshire. About half the states have passed laws that say that the entity that generates the health record, the doctor writing the notes, the MRI facility generating the whatever, they own that health data. And the other half of the states either haven't addressed it or they have court decisions that are kind of all over the place. So it's a morass, basically. So you start putting this stuff on a blockchain, this is an issue that needs to be resolved at some point, right? And obviously federal legislation might be the easiest way to do that, but you know, I fully support this concept of empowering the patient to control their own data. I mean, you know, we just don't have access to that, and trying to get it from doctors is a problem. There's a company out there called My Data, which he's marketing this gizmo basically where patient-generated data like diabetic sugar levels and blood pressure, etc., are stored on a HIP thing, then uploaded to the cloud, and then the doctor has an app on his phone, and he can access that data anytime and see what that patient has, right? And if his blood pressure is out of whack or sugar levels, he gets an alert. So if that doctor's running around, you know, the Cleveland Clinic hospitals, he can see a warning, hey, John Doe has a problem with this. That starts to empower the patient, especially for people who are unable to go to a doctor's office and take their blood pressure or things like that. They're disabled, you know. So this is transformational, and letting patients have control of that data is really important for blockchain, because now you're going to put it up there on a whole new system. That's not a question, it's a comment, but I hope it helps. Thank you.
Thank you. Unfortunately, we're going to have to conclude right here because the next panel is starting now, but my sincere thank Dr. Hanekom. Thank you for taking the time to do this with us. We really appreciate it. Pradeep, Ted, thank you as well. And we'll conclude. Please give them a round of applause. Thank you. Thank you. Thank you.